Welcome to the Deep Dive. Today we're taking a deep dive into a set of revision notes focused entirely on Becker Muscular Dystrophy.
That's right.
Think of us as your study partners. We'll go through the key facts, make it high yield, easy to recall.
Exactly. We're aiming to unpack these notes on BMD definition, cause, risks, the whole lot. How it works, what else it could be, symptoms, tests, management, all of it.
Great. So let's jump right in. According to these notes, what exactly is Becker Muscular Dystrophy?
Okay, so at its core, it's genetic. Causes progressive muscle weakness.
And the notes immediately compare it to Duchenne, DMD.
Yeah.
But they stress BMD is, what, milder?
Yeah.
And starts later.
Precisely. That's the key takeaway up front. Milder, later onset than DMD. It's all down to mutations in the dystrophin gene.
Right, the dystrophin gene. And onset is typically after age 10 for Becker.
Yeah, generally after 10, whereas DMD is much earlier. Another point from the notes, intellectual impairment. Less common in BMD.
Okay. And which muscles are we talking about mainly?
Primarily the proximal ones, hips, shoulders, thighs, those closer to the body's core.
And walking difficulties. The notes say after 16, usually. Big contrast to DMD again.
A very big contrast. And something important the notes mention about female carriers. They can sometimes have symptoms too, maybe some muscle weakness or even cardiomyopathy.
Oh, right. Heart issues. We'll probably come back to that.
Definitely.
Okay, so that's the what. Now the why. What's the etiology here? Why does BMD happen?
Well, it comes back to that dystrophin gene we mentioned. It's on the X chromosome.
Ah, so that's the X-linked inheritance piece.
Exactly. And what the mutations do in BMD, this is really crucial for why it's milder, is they lead to either less dystrophin protein being made or the protein that is made is altered, but it still has some function.
Okay, so it's not completely absent like it often is in Duchenne.
Right. You've got some partially working protein or just not enough of it. That's the key difference explaining the milder symptoms.
Got it. And it's inherited X-linked recessive, so typically passed from a carrier mother to her son.
That's the usual pattern. But the notes also point out it can be sporadic, a new mutation, no family history.
Right, okay. So thinking about who's at risk, what are the main risk factors then?
Well, given the X-linked nature, the biggest one is being male. It predominantly affects males.
Makes sense. And obviously having a family history because of that inheritance pattern.
Yep, those are the main two highlighted.
So let's dig into the pathophysiology a bit. How does that faulty gene actually cause the muscle problems? You said dystrophin is important for structure.
Yeah, think of dystrophin as like a shock absorber or part of the scaffolding within the muscle cell membrane. It helps protect it during contraction and relaxation.
Okay, so in BMD, that scaffolding is wobbly, or there isn't enough of it.
Kind of. Because you have this reduced or partially functional dystrophin, the muscle fibers get damaged more easily when used. There's inflammation.
But the notes emphasize this damage is less severe than in DMD.
Exactly. Because there is some functional protein, the breakdown isn't as rapid or complete as in DMD.
And the result is that progressive weakness and wasting, especially you said in the legs and pelvis.
That's right. Those muscles that work hard against gravity tend to show it first.
Okay. Now, progressive weakness isn't unique to BMD. So the notes list differentials. What else could this look like? This seems super important for diagnosis.
Absolutely crucial. Top of the list, of course, is Duchenne muscular dystrophy. Key differentiator, as we've said. Earlier onset, much more severe.
Right. What else?
Limb-girdle muscular dystrophy, LGMD. Similar sounding, affects hips and shoulders, but the notes are clear. Caused by different gene mutations, not dystrophin.
Okay, different cause. What about spinal muscular atrophy, SMA?
That's on the list too. It's genetic, causes weakness, but it affects the motor neurons, the nerve cells controlling the muscles. So a totally different mechanism.
Okay, nerve issue, not muscle structure issue. And the last one is just myopathies.
Yeah, that's a broad category. It just means other muscle diseases could be genetic, could be acquired. It's sort of a catch-all for other things affecting muscle. Helps narrow it down.
Gotcha. How common is BMD? Epidemiology time.
The notes say it's definitely less common than DMD.
Any numbers?
Yeah, they give figures like around 1 in 18,000 male births in the UK. And globally, maybe 1.6 per 100,000 people, so quite rare.
And just to recap the basics from the notes here, caused by dystrophin gene issues, X-linked recessive, variable severity can be new mutations.
You got it. That variability in severity is a really recurring theme.
So what does this all mean for the person actually experiencing BMD? Let's talk clinical features. What do you see? What do they feel?
Well, the big picture is that progressive muscle weakness, onset, like we said, usually childhood or teens, sometimes even the 20s. It varies.
And what are the sort of classic early signs?
Difficulty running, maybe climbing stairs, falling more often, and that classic sign, enlarged calf muscles, pseudohypertrophy.
Pseudohypertrophy looks muscular, but isn't actually strong muscle, right?
Yeah.
It's replacement tissue.
Exactly, fibrous and fatty tissue. Other early things mentioned, delayed motor milestones if it starts young, muscle cramps with exercise, maybe struggling with school sports.
Well, waddling gait is listed too.
Yep. And importantly, independent walking often continues until the third decade, so their 20s or even 30s, much longer than DMD.
And later on.
Weakness progresses, still mainly in those proximal muscles. But again, variability notes say some might walk independently into their 40s, 50s, even 60s in milder cases.
Wow, huge range. What about other signs? You mentioned pseudohypertrophy, but also wasting.
Yeah, the notes list wasting, too, especially of proximal muscles. Maybe the pseudohypertrophy is earlier, then wasting happens later, or it varies. They also mention myoglobinuria, that's muscle protein in the urine after intense activity signifies breakdown.
Okay. And potential issues with anesthesia.
Yes, that's flagged as a potential complication or sign. Also, a higher chance of learning difficulties or behavioral issues, and critically, those potential complications, cardiomyopathy and respiratory muscle weakness.
Heart and breathing. Always seems to come back to those in muscular dystrophies.
They're often the most life-limiting aspects, especially as the limb weakness progresses slowly. And remember, severity varies hugely.
Okay, so someone presents with these features. How do we confirm it's BMD? What investigations are key?
The first step mentioned is usually a blood test for creatine kinase, CK levels.
Right, the muscle damage marker.
Yeah.
How high does it go in BMD?
The notes say anywhere from 5 up to 50 times the normal level. So significantly elevated. If it's high, that triggers a specialist referral.
The big red flag then. What's the gold standard for diagnosis?
Genetic testing. That directly looks for the mutations in the dystrophin gene. That confirms it.
What about muscle biopsy? Is that still done?
It's listed, less common now with good genetic testing, but it can be useful. It lets you physically see the muscle fibers, check for dystrophin protein using staining, see how much is there, if it's in the right place.
Okay, and EMG, electromyography.
Yeah. That measures electrical activity in muscles. It's not specific for BMD, but it helps rule out other nerve or muscle conditions, those differentials we talked about.
And the heart check echocardiogram.
Absolutely essential. Given the cardiomyopathy risk, you need that baseline check of heart structure and function, and then regular monitoring.
And the notes mention family counseling, too, as part of the whole process.
Yeah, genetic counseling is vital once you're suspecting or confirming an inherited condition like this.
Right. So once the diagnosis is confirmed, how is BMD managed? What do the notes say?
Big emphasis on multidisciplinary care. A whole team. Neurologists, physios, OTs, respiratory specialists, genetic counselors.
Makes sense, given how many systems can be affected. And the goal is?
It's about managing symptoms, enhancing quality of life, keeping people mobile and independent for as long as possible, and dealing with complications proactively.
So practical things like physiotherapy, assistive devices.
Exactly. Physio is key for maintaining strength and flexibility. Assistive devices like braces or wheelchairs when needed. Sometimes orthopedic surgery for contractures or scoliosis. Medications for specific symptoms or complications.
And you mentioned cardiac monitoring before. That's a huge part of management.
Crucial. The notes really stress regular heart checks. And if cardiomyopathy develops, treatments like ACE inhibitors, beta blockers are standard. Early steroids are also mentioned as potentially beneficial for the heart.
What about breathing support?
As respiratory muscles weaken, yes. May need non-invasive ventilation, like BiPAP, especially at night. In later stages, maybe a tracheostomy.
Genetic counseling comes up again in management, too.
Yes, for the patient and family. Understanding the inheritance, implications for other family members, future reproductive options.
And other supportive things listed. Exercise, nutrition, managing cramps, psychological support, even employment guidance. It's really holistic.
It has to be. They also mention, looking ahead, potential future therapies like genome editing, aiming to fix the underlying mutation.
That's hopeful. But for now, it's ongoing monitoring and tackling complications as they arise.
That's the reality of management currently.
So thinking long-term then, prognosis. What's the general outlook and what are the main complications to watch for?
Prognosis is, again, variable, generally milder, slower progression than DMD.
Outcomes range from, what, near normal lifespan in some to more significant issues?
Pretty much. Advancements in care, especially cardiac and respiratory, have definitely improved things. But regular monitoring and managing those complications is absolutely key to that improved outlook.
Life expectancy is often reduced compared to average, but better than DMD.
Generally, yes. And the notes highlight a really critical point. Cardiomyopathy is a major cause of death in BMD. The heart is often the limiting factor.
Which really makes you think, given that huge variability in how people do, what actually influences whether someone has a milder course versus more severe complications. The notes don't spell it out, but it must be tied to the specifics of their dystrophin mutation, right?
Yeah.
Or other genetic factors.
Almost certainly. The exact nature of the mutation likely plays a huge role in how much functional dystrophin is produced. Research is ongoing there.
Okay, and what about the specific list of complications? Musculoskeletal.
Things like joint contractures, joints getting tight and stiff, scoliosis, curvature of the spine, and general problems related to reduced mobility.
And cardiac, we've covered cardiomyopathy, but also arrhythmias, clots.
Yes, irregular heartbeats, increased risk of blood clots. Management involves monitoring, meds like ACE inhibitors, beta blockers, maybe anticoagulants, and in very severe cases, even heart transplant is considered.
Anesthetic complications, that sounds scary.
It's a specific risk, reactions similar to malignant hyperthermia or dangerously high potassium levels with certain drugs. Anesthetists need to be aware.
Respiratory muscle weakness leading to breathing problems, similar to DMD.
Correct. And finally, just pain, lower back, spine, legs are mentioned as common issues.
Right. Well, that brings us towards the end of this deep dive, unpacking these revision notes on Becker muscular dystrophy.
We've gone through the definition, the genetics, the risks, how it works in the body, differentials, how common it is.
The clinical signs and symptoms, investigations, the whole management approach, and the outlook and complications. Phew.
Yeah, quite a journey. But hopefully, breaking it down like this helps make sense of it all. Remembering that core difference from DMD, the presence of some dystrophin, is key.
And I think that point about cardiomyopathy being such a major factor in prognosis, even in this milder dystrophy, really stands out. It underlines why that comprehensive lifelong care is so vital.
Absolutely. Vigilant monitoring, especially of the heart and lungs, makes a huge difference. Reviewing these key areas, particularly the distinctions and major complications, should be really high yield for revision.
Definitely. And here's a little something for you. If you're looking for more high-yield revision material, like the notes we've been digging into, you should definitely check out PathMSRA.com.
And also freemsra.com. Both have excellent resources tailored for effective learning and revision.
Great stuff. Thanks for joining us on this deep dive.
Hope it was helpful. Keep learning.